what is the difference between systemic sclerosis and scleroderma?
Scleroderma means hard skin, and basically that's the umbrella term. So, scleroderma includes systemic sclerosis,
What are the early signs of scleroderma that they should pay attention to?
Raynaud's, swollen skin, and GI, gastrointestinal, and lungs. Those are the most common.
They go on Google, they research it, and they take Dr. Google as their partner in their journey. And that should not be the case.
Knowledge is really important. I think you need to be careful about support groups. Some support groups are exactly that, support groups, which help support, which help give you knowledge, etc. Some support groups are just a bunch of war stories about how awful things are. So, not all support groups are good. If you want to try one out, great, but don't get drawn in if it's not what you want.
Today, we are diving into a new topic, systemic sclerosis, a very complex autoimmune disease with profound impacts, especially on women. We will unfold the early signs, the symptoms. We will discuss how it is to live with systemic sclerosis. And of course, we will be discussing the latest treatment options available today and what is coming on the horizon. But before we start, I am thrilled to introduce you my distinguished guest, Professor Daniel Furst, who is one of the most respected physicians and scientists in the world for his lifelong contribution to the field of rheumatology, but also his focus on systemic sclerosis. And without further ado, let's welcome Dr. Furst to my podcast, Thriving with Arthritis.
Good day, and I appreciate your having me on the program very much. Thank you.
Let me tell you a little bit more about Dr. Furst. He is a distinguished professor of medicine at UCLA. He is a graduate of Johns Hopkins University and he completed two fellowships, rheumatology at UCLA and clinical pharmacology at UCSF. He is the first Carl Pearson Professor of Medicine at UCLA, and he is also a prolific author of more than 650 articles and 15 books on his name, including extensive research on clinical pharmacology, on our drugs, biologics or not. And he is also the driving force of writing guidelines for the American College of Rheumatology about our therapies today. Dr. First, without any hesitation, I know that you are the authority in the field. And today I invited you, and I'm very appreciative of your time, and I know patients will be too, to discuss about systemic sclerosis. And my first question is a question that confuses many patients. Why do we call it systemic sclerosis? And what is the difference between systemic sclerosis and scleroderma?
It's a very good question. Scleroderma means hard skin, and basically that's the umbrella term. So, scleroderma includes systemic sclerosis, and I'll talk about that a little bit. But it also includes localized forms like something called morphea, where it's just the skin, or linear scleroderma, where the skin is involved in lines in various parts of the body. And ultimately, other diseases that look like scleroderma and have hard skin but are not necessarily scleroderma. For example, there are some kinds of thyroid disease that look like scleroderma. Systemic sclerosis, on the other hand, is exactly that. It is skin that is systemic. So it's disease that's systemic plus hardened skin most of the time. And it's due to the fact that there is something that starts it. For example, in Japan, there was a sleeping medicine. In Spain, there was a cooking oil. And in South Africa, was a particular mine that was associated with it. But whatever sets it off, it begins to cause the immune system, our body's defense system, to turn against itself. In addition, the blood vessels are involved. We see that as what's called Raynaud's phenomenon, where the skin, where the hands change color to the cold. And the vascular or blood vessel changes affect the immune system and vice versa. And both of them result in turning on cells called fibroblasts. Fibroblasts are those cells that kind of hold us together, but they do more than that. And one of the things they do is produce collagen. Collagen is the same stuff you see when you cut yourself and you have a scar, but that collagen forms inside the body and so can interfere with multiple organs. And the collagen turns on the immune system. So it sets up this round the sort of circle of increasing disease. And the systemic sclerosis specifically affects the internal organs. The principal ones are the GI tract, the Raynaud's, skin, of course, the lungs, and other organs too.
Because you started to mention all these organs and the involvement in systemic sclerosis, I know patients, they are confused, especially in the beginning of disease. And I would like you, if you can, to educate them. What are the early signs of scleroderma that they should pay attention to?
That's another good question. 90% of people who have scleroderma get this thing called Raynaud's phenomenon. This is the change in color of the hands or the feet, can even affect the nose, the tongue, the ears, but to cold and stress. And what happens is that the blood vessels constrict, and then because there's no oxygen and no blood flow, the hands in this case turn white. And when there's no blood flow for a while, then because there's no oxygen, they turn blue. And then the body says, wait, we got to do something about this. And they open up the blood vessels and it turns red. So, in a sense, a very patriotic disease. So, it's white, blue, red. And if the blood flow is cut off long enough, then you can get ulcers of the skin, breakdown of the skin, which can be very painful. So, that's the first thing. And then much of the time, because there's not enough blood flow and the immune system has become active, the skin can become swollen, not just the joints, but the skin. And people feel swelling of the hands and they can't make a good fist. So, swelling is another very early sign. And it turns out that although about 50% of us have a little heartburn, when you have scleroderma, that heartburn gets a lot worse. That doesn't mean that if you have heartburn, you have scleroderma. But if that heartburn really gets worse in the context of Raynaud's, etc., then you should think about what else it might be. The next most common thing is lung involvement. And what does that mean? Well, you know that collagen that I talked to you about before? That gets in the lungs. And so it gets in the way of exchange of oxygen. And so we can get short of breath. And if the shortness of breath is significant, and again, in the context of Raynaud's and swelling, you should get it checked out. That does not mean you have scleroderma. By the way, 50% of people who have Raynaud's have nothing more than Raynaud's. So just because you have Raynaud's doesn't mean you have scleroderma. Anyway, getting back to the lungs. So that's another organ that gets involved. And if your lung is involved with the scleroderma, it really does need treatment. So, Raynaud's, swollen skin, and GI, gastrointestinal, and lungs. Those are the most common.
Thank you for making those like stand out, because this is important for patients to understand. I often have patients that will come to me for Raynaud's thinking that they have scleroderma or forms of changing in the skin color, especially of the hands, especially after exposure to cold weather, that they will believe even that this is Raynaud's. And I love the fact that you explain the three phases of Raynaud's, because what I actually do, I ask the patient to tell me exactly how they experience it. And I judge based on their description how they describe it, if this is really Raynaud's or just vasoconstriction or closing of the vessel because of the change in temperature or changing emotions. There are many forms of systemic sclerosis, but I would like to talk about one that many people do not know that exists. And this is, this reminds me about a case that I had years ago when I was a fellow, a case that I actually published about a young lady that presented to the hospital with horrible episodes of Raynaud's, and she actually had ulcerations of her fingers. And on top of that, she had reflux, a lot of acid reflux, and she had shortness of breath. And I remember she was in her early 30s. And the question was, what is she having? Is this an autoimmune disease or not? So that's how we discovered that might be something more. So, can you tell us a little bit about systemic sclerosis that does not have skin involvement?
So that's called scleroderma sine. That's Latin for not. Sine scleroderma, without hard skin. It occurs in about 5% of people.
Mm-hmm.
And it can happen, and it is a source of misdiagnosis, and it's hard to define sometimes. So, how can you define scleroderma sine scleroderma? Well, it's specifically with the things that your patient had: Raynaud's and GI involvement and shortness of breath. But nowadays, we also have some blood tests that can help. We have some blood cells tests, and one of them is called SCL70 or anti topoisomerase. You don't need to remember that. Um, that occurs in about 40% of people who have scleroderma. So that means 60% don't have it.
Mm-hmm.
So if you have it, it's useful in terms of making the diagnosis. If you don't have it, that's good, but it doesn't mean you don't have the scleroderma. If you have that in the setting of the what we talked about before, then you have to think more about it being scleroderma sine scleroderma. What about scleroderma sine scleroderma? Is it better or worse prognosis? Well, in fact, it's about the same prognosis. It's not worse, but because it's the internal organs, we have to be a little extra careful. And we can treat it. And we'll get to that, I'm sure. But I have a lecture called Scleroderma is a Treatable Disease because many people were told if you have scleroderma, you're done. Go home, get ready to die. That is simply not true anymore. And we'll get to that.
I love the fact that you mentioned that. Thank you so much.
Well, it's very important. This is a very treatable disease now, and it's getting more treatable all the time. So, with scleroderma sine scleroderma, you perfectly described the person who has it. And we should not ignore those patients. We should keep that available. I don't know if you're going to get a chance, but we might want to talk about what's called limited systemic sclerosis. Do you want to ask something about that, or
Yes, yes. I would love you to explain the difference between the limited and the systemic sclerosis. Let the patient know about what is limited systemic sclerosis.
Now remember, we talked about scleroderma, that's the umbrella term. And then we talked about systemic sclerosis, that's a specific term, but we can get even more specific. There's a kind called limited systemic sclerosis and a kind called diffuse. And that means it relates to the amount of skin thickening that occurs. There used to be something called CREST syndrome, calcinosis, Raynaud's, esophagus, sclerodactyly, that's hard fingers, and telangiectasia, that's red dots. But that occurs in both types and shouldn't be used anymore. Limited scleroderma involves more limited skin. So, for example, it's distal or beyond the elbows and knees, and including the face, but nowhere else.
Hmm.
So, what difference does that make? Well, it does make a difference because patients who have limited scleroderma may have more trouble with their GI tract. They may have more ulcers because it's a vascular disease more than the diffuse, but they don't tend to have as much lung involvement. So, lung involvement in limited scleroderma comes much later. So, we can spend more time trying to treat their GI tract and their skin and not worry about so much internal organ involvement. Diffuse disease, on the other hand, has more skin involvement. So that includes the upper arms, the trunk, thing like that. And so it's called diffuse because there's more skin. Those are the patients who early on tend to get more lung involvement or more kidney involvement, things of that sort. So if you have diffuse disease, we need to jump in earlier to treat. So diffuse, you jump in. Limited, you can take your time.
That's a good assessment, and that gives patients a good perspective about what they can expect. Now, you mentioned about the role of antibodies, and I would like to dig a little bit deeper about how we make the diagnosis, because I had patients that will come to me with a positive SCL70 antibody. Does that mean that they have scleroderma?
Your questions are right on target. So, first of all, 90% of patients who have scleroderma have a positive anti nuclear antibody. And there are multiple reasons for that. Basically, an ANA says your immune system is overactive. And it depends how much ANA, etc., a lot of details there. But first of all, the ANA is very frequent. It does not mean you have scleroderma, it means you have an overactive immune system. An example is if any member of your family has an autoimmune disease, you are more likely to have a positive ANA, but that does not mean you'll get an autoimmune disease. And then there are antibodies that occur that are typical of scleroderma. One of them is the SCL70 or topoisomerase. Another is the anticentromere. Another is the RNAP3. Another is a THO TH1 ratio. Let's take those apart. SCL70 is more associated with the diffuse disease about which we spoke before. If you have it, then you have to watch. That does not mean you're going to get it. So, for example, people who have certain kinds of hepatitis have that antibody. People who have something called pemphigus, another skin problem, have that antibody. But it means you need to pay attention. On the other hand, the anticentromere antibody, another blood test, is more typical of the limited scleroderma. Again, 30 to 50% of people have that. And it is more associated with limited than diffuse. Very few times do you have people who are both anticentromere and SCL70. The RNAP3, it's yet another antibody, and it is associated with certain associations, something called pulmonary hypertension, where the lungs get involved, and other things like kidney problems. And then there's one I didn't mention called the RNP. That's an antibody that tends to occur when you have a little of this and a little of that. So scleroderma a little, RA a little, but not all of any of them. And that's actually a good antibody to have. If you're going to have that, you're unlikely to get into real serious trouble. And then there's one called THO-TH1. That isn't used very much right now, but it's typical of a certain kind of scleroderma. So if your doctor says, listen, we need to look, he or she should get an ANA and maybe the SCL70 and anticentromere. And then, if those are positive, they need the help of an expert. And remember, this is a quote team sport. It's not one person, it's a bunch of people. And the patient is very, very important in it. What she needs is sort of the key. So she should be part of the team. And it's going to need more than one kind of doctor. Rheumatologists really do well as the quarterbacks. But sometimes you need a lung doctor or a GI doctor or a heart doctor or not. But it's a group of us working with the patient.
I appreciate the fact that you said that the patient is the center of this group, because a lot of my patients, and I'm sure your patients will also ask you, is they would like to know what they can do, what lifestyle they can approach to get better or to feel better with systemic sclerosis. What do you teach your patients?
So, you know, any disease is driven in part by ourselves, the patient. How we feel about it is very important. If we're depressed, if we're just, oh God, there's nothing I can do, you'll get worse faster. If you say, damn it, I'm not going to give in to this disease, I'm going to do something about it. I'll change my diet. I'll change the things I do. I'll stop smoking. I'll do a better lifestyle. You will do better as a patient for two reasons. One of the things that happens in people with chronic disease is they feel a loss of control. They say, no matter what I do, it doesn't make a difference. It's not true. What you do makes a huge difference. The power of your mind is really important. In study after study, 30% of the response to a medicine is the power of the mind, not the power of the drug. So the mind is super important, which means you, the patient, need to keep control of what's going on. Physical therapy, rest, exercise, the things you know, the things we all know, the things that are so hard to do, and I know that. Nevertheless, the more of that you can do, the better off you'll be.
That is so powerful, because we all know what we need to do, but it's hard to implement when you find out about this disease. And many patients, I think I mentioned that to you before they come to us, they go on Google, they research it, and they take Dr. Google as their partner in their journey. And that should not be the case. They should come to us, they should come to you, the expert, and they should figure out what is a life with systemic sclerosis. And I'm going to ask you, do you think patients with systemic sclerosis can have a normal life?
Systemic sclerosis is a whole range of diseases, just like the other rheumatic diseases. RA is a range of diseases. Lupus is a range of diseases. But when it comes to scleroderma, some patients will have essentially a normal life. Some patients will not do so well. And I got to say this about Dr. Google. There's a thing, it says, not everything that is on Facebook is necessarily the truth. Signed, William Shakespeare. Okay? So remember, Dr. Google is not William Shakespeare. Okay? Anyway, back to this. Um, so I think that I must say, I've lost my place. Where am I?
So we were talking about if patients can have a normal life, because when they
Oh,
find out about the diagnosis, like you said, their whole life is shattered. The reading that they do on internet is extremely disturbing, and they don't see the light at the end of the tunnel. But as you said, the power of the mind is so critical, and getting the right information from the right people who have experience, who have diagnosed and treated patients and followed patients for years. Not only did they just heard about it.
that's absolutely true. Knowledge is really important. Um, in California and the West, our organization is California Scleroderma Foundation. On the East Coast, it's what's called the National Scleroderma Foundation. Um, those are two very good sources of information. Most of us have support groups. I think you need to be careful about support groups.
I agree.
Some some support groups are exactly that. Support groups, which help support, which help give you knowledge, etc., which try and do education. Some support groups are just a bunch of war stories about how awful things are. So, not all support groups are good. If you want to try one out, great, but don't get drawn in if it's not what you want. Okay, so um, normal life. I think it's only fair to say that it's not going to be a completely normal life. If you were a long distance marathon runner, you may not be able to do 20 miles, you may only be able to do 10. But one of the things I tell people is you are not scleroderma. So you may have scleroderma, but you need to be you, and you shouldn't change that.
We did not speak before, but I tell the patient the same thing. You have a disease, you are not the disease. Unbelievable. Um, Now we're going to switch the subject a little bit and we're going to talk about treatments. And I know you probably know so much more than anybody else that the treatment for scleroderma evolve over years so much. Can you tell us what is the approach for the treatment these days? And we'll talk a little bit more about what is coming on the horizon.
So this is merely the subject of a 2 hour lecture. Don't worry, we'll do it. But as I said before, look, scleroderma is a treatable disease. Each person is treated somewhat differently. But for example, and this isn't all by any means, there's a medicine called methotrexate that's been used in rheumatoid arthritis for 30, 40 years now. We've done research on it. And it works very well for scleroderma if it's only the skin and early on. Another medicine called Celcept or mycophenolate is used by many, many patients to help with the joints, although there are better medicines for it, and to help with the skin and to help with the lungs, etc. So it's used by many people. It's a pill, which is great. There's another medicine that's been used in rheumatoid arthritis by many, many thousands of people called Actemra or tocilizumab. I challenge you to say that quickly 3 times, but Actemra. And it has been approved for use in scleroderma, and it helps particularly in the lungs. But it also helps a lot with the joints and the muscles. And it eventually, not as well as mycophenolate, it helps with the skin too. There's also a medicine called rituximab, and that medicine has been used many, many, many times in multiple autoimmune diseases, including rheumatoid arthritis, including a disease called lupus, etc. And it works too in scleroderma if the others don't. And then there is the medicine that really cures the disease, but it's a very dangerous medicine. And that's called stem cell transplantation. And the good news is it really works. The bad news is it's really dangerous. 5% of people die from the procedure. So you got to be careful to whom you give this. There are also other things like intravenous immunoglobulins that have been used. Not much data to support it, but it's been used. And it seems to have perhaps a place in particularly bad GI disease. There's also something called plasmapheresis, where you change some of the cells in the body. There's even less data for that, but it has been used as well. And other diseases, other treatments are also coming down the pike. I think it's worth saying that the things I just talked about, and I just touched on them, is for the disease overall. But, for example, we have really good treatment for the GI tract. And you don't have to have heartburn. You don't have to have difficulty swallowing. You don't have to have bloating, etc. There are treatments for that that go alongside the others. Likewise, there are treatments for the joint pains and muscle weakness. And there's treatment for depression. Most patients with scleroderma go through a phase where there's some depression until they realize what we said before: you have the disease, you're not the disease, and that you actually can have a life and you can do many things that are relatively normal. So we need to treat all of you, not just the overall disease. So when I say scleroderma is a treatable disease, I mean it. I think with a combination of therapies, with help from you and your regular doctor, we can do a pretty good job in making you feel better and function better.
You gave us so much knowledge in less than 5 minutes. So that topic that was initially 2 hours, you were able to condense that. But that gives patients such an understanding about the fact that they have multiple options. And as you said, my philosophy is also treat the patient or treat the disease. Is that having a comprehensive understanding of where you are, what are your options, and you, the patient, contributing to that by making the right choices in your life, you can have a good outcome even with this disease. Now, I know your time is valuable, and I appreciate the fact that you were able to jump on this podcast with me. And I know patients will be very interested to work with you. How can they find you?
Yes. I have a website under Daniel Furst, of course. I You can Google me on Southern California scleroderma and rheumatology, and I would be glad to see you. Sometimes I see patients from basically all over the country and other countries. So sometimes I need to see you only once or twice, and a lot of that can be done by telemedicine after a while. But I need to see you sometimes. Telemedicine's good, but telemedicine isn't seeing you, the patient. And there is a difference, and you know that. So you can get hold of me that way. Um, I am doing multiple clinical trials. And should you need one of those would be available as well.
If patients from outside the United States would like to contact you, they can contact you through your website.
The website and through this Southern California Rheumatology and Scleroderma and Rheumatology Center. Um, the phone number, phone numbers. I have a good team. I really do. They'll try and get back to you. Is 310 That's 310-297-6812.
For those interested to contact you, I will list your website and I will list the phone number in the bottom of this video so people could have the chance to talk to you about their disease. Dr. First, thank you very much. I appreciate your insight and I appreciate the fact that you took from your so valuable time to give back to patients. And I hope to see you in a future episode where we talk only about the treatment of systemic sclerosis.
And I need to say something here. You've done a great job and and using your own time to make this happen. So good on you. Take good care of yourself.
I
All
appreciate
right.
that. Thank you very much. Have a wonderful day.
Bye bye now.